Good evening, everyone, and welcome to the EUROGEN webinar programme. Just before we get started, I wanted to take a couple of minutes to explain a little bit about what a European reference network is. EUROGEN is one of 24 European reference networks, all covering different medical fields. The ERNs were created by the European Commission in 2017. And they're networks of highly specialised healthcare providers who all deal with patients with rare or complex conditions that need highly specialised healthcare. The aim for us as a network is to try to deliver faster specialist evaluation and more equitable access, high quality diagnosis, treatment and care for patients with rare urorectogenital diseases or complex conditions that need highly specialised surgery usually. So what are the activities of the network? Well, we collaborate using something called the Clinical Patient Management System, and that's a fully secure IT system given to the ERNs by the European Commission that enables us to have virtual cross-border multidisciplinary virtual MDTs between the different centres and experts. And this service is free to any healthcare professional in the European Union that requests it. A second activity is we also collaborate on education and training activities, such as this webinar where we can share the views of experts widely, and we also have a clinical exchange programme. We are also working on a EUROGEN registry, and we hope that contributions from the various clinical teams in our now 57 hospitals will help to provide the evidence base for future work on guidelines and research. So this evening's webinar is a collaboration between our ERN, ERNICA and the Anorectal Malformation Network. We work with supporting partners in order to try and maximise the impact for patients. So this evening's webinar is about gonadal surgery and pathology in DSD. And we're extremely grateful to have Professor Gilvydas Verkauskas, who's head of the Children's Surgery, Orthopaedics and Trauma Centre in Vilnius University. We have Darius Dasevicius, who's a pathologist at the National Centre of Pathology, again in Vilnius, and Vilnius is a very active member of our network. And then finally, we have Professor Faruk Hadziselimovic, and I do apologise, professors, if I didn't get the names quite right. Okay, without further ado, thank you so much for sharing your expertise and knowledge with us this evening, and don't forget, feel free to ask questions at the end. Thank you.
Hi, my name is Gilvydas. I represent Vilnius University Hospital as a healthcare provider in rare diseases and EUROGEN from Lithuania. I will present this topic together with my colleague and friend Darius Dasevicius from National Pathology Institute, who became responsible and collaborating, deciding on histology of DSD patients, and together with Professor Faruk Hadziselimovic from Switzerland. We are all not only friends but also part of the team headed by Faruk in Cryptorchidism Research Institute, and our research is mainly based on cryptorchidism. But from time to time we share our ideas about DSD also. Therefore, I've chosen to talk about that. How to change slides? Okay. We have no conflict of interest. Why DSD and EUROGEN? Because EUROGEN, as you probably know already after all these webinars, is divided in 3 work streams, and one of them is covering complex genital reconstructions, which is in DSD patients. And all these diagnosis of DSD are definitely rare because they affect fewer than 1 in 2,000 patient population. I will not stop too much on the definitions because still we have general consensus which was made in 2006 by Laws Wilkins, Pediatric Endocrine Society and European Society for Pediatric Endocrinology consensus group. Also, it has been changing all this time quite significantly, mainly because of ethical issues due to gender-based diagnostic labels. But this consensus is important still because defining main steps of diagnosis and surgical management. This has also been changing during that time, and also in consensus it was called disorder of sex development. Since that time, differences of sex development were adopted, and in some centers they use variants of sex development. But let's just keep this DSD. This is a complicated subject, and for me, probably one of the best papers reflecting that complication and complexity of the subject is that of the Petra de Satter. Probably I am not correct in pronunciation, from Ghent, Belgium. And the paper is called Crossroads of Medicine, Human Rights and Politics, based on resolution of 2017 on Parliamentary Assembly of the Council of Europe, arguing that the practice of surgically modifying intersex children's genitals without medical necessity and without consent of the person concerned becomes human rights violation. Calling for discussion to create legislation that leads to the best possible outcome for people with DSD. Since that time, again, European Society for Pediatric Urology and SPU, which is Societies for Pediatric Urology of America, made a consensus statement in 2020 on management of differences of sex development, and main statements are that specific diagnosis should be used rather than umbrella team like DSD, and multidisciplinary individualized patient and family-centered care, individualized not mandated management, and that complex medical problems should remain in the purview of the family and the expert medical team, and thus should not be legislated. Okay, but that information again is easily found on internet. If you follow the ESPU, European Society of Pediatric Endocrinology, IDSD website, and many other sites which are discussing and this problem and may answer to many questions. The topic of our webinar today is gonadal surgery. Also, the role of pediatric urologists, and most of members of EUROGEN are pediatric urologists or adult urologists. It is also participation in multidisciplinary team discussion, genital reconstruction, endoscopy, laparoscopy, drainage, and other roles. But let's just concentrate on gonadal surgery. And this is important for diagnosis. Not umbrella one, but real diagnosis, sexual development, and prevention of malignancy, mainly. There are other indications, we will talk about that. Risk of malignancy is up to 40% in individuals with these genetic gonads, but this is again based on small numbers, cases series, and different age diagnosis. Different age of gonadal surgery, which is important when you put testicles down or when you take this genetic tissue from that gonad. Again, total or partial gonadectomy is sometimes difficult to decide, and always we should remember multidisciplinary team and parents to discuss that. We think that at least a biopsy for all DSDs is indicated, or better to say beneficial, for diagnosis, for cancers, for research, for fertility prognosis, fertility treatment, and cryopreservation. A pathology of gonads consists of testicular pathology, ovarian, and tumor. Mainly it's testicular again. A pathology of testis, we search in pathology of testis in different diseases. We search for reproducible, cost-effective technique to recognize germs, Sertoli Leydig cells, and tumor precursors. For example, this kind of biopsy in one of our patients, all the patients in partial gonadal dysgenesis, a 15 years old boy with dysgenetic testicles. Really, from that technique, we can only say that this is yes, it is dysgenetic testicle in a 15-year-old boy, but we may say nothing about status of germ cells, of tumor precursors, or whatever. And if you made a modification of the technique, you make a semi-thin section, you make fixation of tissue with a special fixators suitable for that kind of investigation, like glutaraldehyde, like Buen, like Steve fixatives. And you make especially what we would like to stress altogether, that the semi-thin section, and it's 1 micrometer. Then you can really differentiate germ cells, Sertoli cells, and recognize much more in that biopsy. So I invite Faruk to change and to talk about importance of testicular biopsy in children.
Okay, I'll take this. I cannot move the slide, so I will tell you to move the slide. So give me the next slide.
Yes.
But today I would like to talk about importance of prepubertal testicular development to be analyzed by a specific section, semi-thin section. It's not so young. We started it sometimes in 70s. And but still, up to date, it is not generally accepted by most of pathologists, probably because it is a little bit not only expensive, but takes some time in preparing the tissue. Nevertheless, the testicular development, we can here in this session, we will divide it into 3 different parts. First, I will start just to show some overview about the germ cells. In fetus, we have a gonocytes, an upper part of a slide, and that goes to the fetal spermatogonia, which is the largest spermatogonia in prepubertal testis. And then it transforms from the basal membrane to AP and then AD spermatogonia. This is a specific spermatogonia. It is a stem cell for all other sperm. And then goes to something what we described as a spermatogonia, which is in between from the spermatogonia and AD spermatogonia, then to B spermatogonia. Finally, after building the blood testis barrier in puberty, the sperm develops up to sperm. Next slide, please. The Sertoli cells, which are principally the largest part of the cells in prepubertal testicular seminiferous tubules, we divided 74 or 76 with late Harumichi Seguchi from Japan in SF, fetal Sertoli cell, then SA, SB, and finally SC, that's the adult Sertoli cells. You see how the Sertoli cells transform and how different they are before and after puberty. Next slide. And finally, to the Leydig cells, when I started to work with 17 section, and that Leydig cells at that time were not visible in a normal session in pre-puberty. So in textbook on histology, it simply doesn't appear. All the endocrinologists knew that there must be Leydig cells. After stimulation, they get the testosterone increase. It was only possible when we did the 17 section. Now, there are 3 different types of Leydig cells which develop from the precursor. Fetal Leydig cell in the first 6 months, important for mini puberty, then goes to the juvenile Leydig cells, and finally in adult Leydig cells. You see those crystalloids from Reinecke. This is a typical size of adult Leydig cells. Next slide, please. Now, the most important cell which give us the opportunity by doing the testicular biopsy to find the perspective of fertility is AD spermatogonia. This AD spermatogonia, you see it on the left side with a typical nuclear halo, is important to be found in any testicular biopsy to say something about fertility potential. On the right side, you see the development of the AD spermatogonia during mini puberty increase, and then again increase something between 4 and 6 years of life, and definitely increase the number during the puberty. Next slide. The other advantage of 17 section is that we can see the tumors without staining, without seminoma, without doing anything more. This is a classical picture on 17 section of a seminoma. Carcinoma in situ with this typical seminoma cells, a lot of glycogen, peripheral rim, and nucleus round with several dark stained nucleoli. We also had developed a specific antibody determination with CD44 for seminoma. It was published in Cancer, and we found that in our cases at that time, from 3,659 cases, 17 carcinoma in situ, it means 0.46%, but totally in cryptorchidism, in what we analyzed, incidence of carcinoma in situ is 0.27.
And the consensus of 2006 states that the testis in patients with complete androgen insensitivity and those with partial androgen insensitivity raised females should be removed to prevent malignancy in adulthood. Parental choice allows deferment until adolescence, recognized that the earliest reported malignancy in complete androgen insensitivity is at 14 years of age. Recently, a paper based on IDSD registry was published on large number of multi-center patients. It's 166, and they found no invasive gonadal germ cell cancer in women with complete androgen insensitivity. Of the 142 women with complete androgen insensitivity who had gonadectomy, germ cell neoplasia in situ was reported in only 2, whereas no premalignancies were reported in adult men with partial androgen insensitivity. Taken together, our data highlight the lack of standardization concerning gonadectomy in androgen insensitivity syndrome and suggest a low incidence of invasive gonadal germ cell cancer in androgen insensitivity syndrome during adulthood. Therefore, individualized decision making, taking also into account patient preferences, seem appropriate. When making biopsy, nevertheless, in these patients, it's very important to make it properly. Like, for example, this case is a 1-year-old, 7 months patient with complete androgen insensitivity syndrome. Could you comment, Faruk, on that?
Well, this is principally one of those general slides what you see with a normal pathological stain technique. We principally see some germ cells in a tubuli. The definition what type of a germ cells is not possible. The fibrosis of interstitium is also here already, and the Leydig cells which principally should be seen is that's a problem of this technique. Is not seen. They are not seen. We have to stain them to find them. We can just think that this one or other cell could be, but it's nothing. So that's my comment.
Yeah, thank you. Yes, what really I wanted also to stress with that slide, that we should probably choose a different technique if making biopsies in patients where we must answer some questions, because superficially it looks like something like normal testis in 1-year-old. And that was a common belief that prepubertal patients with complete androgen insensitivity syndrome have normal testicular development. But abnormal testicular development is obvious as early as the first month of age. At this age, the transformation of gonocytes into adult dark spermatogonia is absent, even though the total germ cell count is within normal limits. In 80%, the transformation of gonocytes into dark spermatogonia failed completely, while in 20%, the transformation occurred but was incomplete. So what would be suggested in these children is biopsy early. We find ID, then we cryopreserve, and during puberty, we evaluate for carcinoma in situ. X6Y or Klinefelter syndrome. It is during childhood, spermatogonia of AP and AD type are found in half of biopsy specimens. In the specimens with germ cell present, the average number of AP and AD spermatogonia per seminiferous tubule is reduced, but they are present. The adult testis is atrophic and histologically exhibits severe tubular atrophy, peritubular hydrenosis, and nearly complete loss of germ cells and Sertoli cells. Again, why not biopsy early for treatment, maybe, and cryopreservation? Do you think, Faruk, it is reasonable to treat these kind of patients like X6Y Klinefelter or persistent Mullerian duct syndrome, for example?
Well, the problem here is that Klinefelter syndrome, the hypothalamo-pituitary gonadal axis is normal. They react later as a hypergonadotropic hypogonadism. And we find AD spermatogonia. So if you get those boys with AD spermatogonia, yes, you should not treat them. But there is also frequently combination Cryptorchid testis and Klinefelter. So then the pituitary gonadal axis may be hampered. That's not as it usually is. So there, the biopsy, if they are not found AD spermatogonia, then some endocrine and evaluation should follow, and then probably we can treat these patients. But look, this point, we have pretty good results from treating Klinefelter later in life by assisted by taking a biopsy and then take out what we find in that biopsy and treat the women. It's TC, Vixi. So I don't think so that we should treat the Klinefelter as we are treating Cryptorchid's boys in the moment.
Yes, and cryopreservation is very fast developing recently, and it is still experimental in DSDs, but it is not anymore experimental in some other forms of infertility children. So, for example, after cancer treatment, taking and cryopreserving gonads before cancer treatment, and then using it afterwards, after puberty.
Gilvydas, do we have a results of these kids when they are getting adult and producing the children?
Already there are results presented in its case reports, but it's positive results, and we started cryopreserving it in Vilnius already.
Good.
So it's
you have the results.
Yeah, no, we don't have still, but some centers have already. Okay, returning to yeah.
Okay, at the end, go ahead.
Yeah, returning to persistent Miller-Rand duct syndrome, which is autosomal recessive condition. It was found that during puberty, germ cell histology range from normal number and morphology of late spermatids to severe oligospermia. In infancy, in 8 out of 10 testes, a few AD spermatogonia were observed. During puberty, 2 biopsy patients, it's an old paper I found, had late cell hyperplasia and severe germ cell arrest despite early orchidopexy. Defective Sertoli cell metabolism was thought to lead to late cell hyperplasia with oligospermia.
Not been proven. That is not that is just hypothesis.
Yes, it's hypothesis.
Okay.
Fertility is rare but possible in persistent Miller-Rand duct syndrome. The incidence of testicular cancer reported was 18 to 33%. Again, this incidence is really difficult to judge. Very few reports. Biopsy and treatment early. That's why we think that biopsy is very important in these patients. Probably treatment is possible, and of course rebiopsy later, and assisted techniques and cryopreservation also early when we still have AD spermatogonia. Probably the most of specialists would say, why should we biopsy congenital renal hyperplasia patients? But it is known that the fertility is markedly reduced in females with classic salt-wastic form. In non-classic form, it is also present, and phenotypically they look like polycystic ovary syndrome. In boys, the rate of paternity compared with age-matched controls was markedly diminished in a paper published in 2010. Usually, proper adjusted steroid therapy is helpful, but in testicles, for example, we know that benign testicular adrenal rest tumors are found in 27 to 47% of males with classic congenital adrenal hyperplasia, and it is sometimes unresponsive to or very advanced at the presentation, leading to irreversible damage to testicle. Therefore, testis biopsy is important. Probably sometimes testis preserving surgery, and sometimes probably cryopreservation also should be considered. A very interesting candidate is 5-alpha reductase deficiency. These children, they are very feminized at birth, and then spontaneously masculinized during puberty. And if you look at biopsies in small children, on the right side you see biopsies from 5-alpha reductase children. On the left, from cryptorchid, bilateral cryptorchid patients. And what you may notice in this magnification is not very big, but you may notice that the difference is evident. Biopsy from isolated bilateral cryptorchidism looks much worse than 5-alpha reductase deficiency, although they don't have action of dihydrotestosterone. And but you see a lot of germ cells and you see ADs. This is a paper of Faruk, so probably he would better comment on that. But the blue line is normal. The dotted blue is lowest normal, and the blacks are cryptorchid patients. And the red spots, these are 5-alpha reductase. In infancy, in small children, it looks quite normal. Very normal, I would say, yes. And later it becomes worse. Testis lacks spermatocytes but had AD spermatogony and a normal germ cell count. As I mentioned before, with the slide before, that later these testicles become worse, and only few reports of assisted and spontaneous paternity, probably in patients who are compound heterozygous. Therefore, treatment of infertility is complicated, and probably we should think about cryopreservation and other techniques. Faruk, maybe some more comments on that?
It's everything okay. That's enough. Good.
Yeah, let's go forward. Over testicular DSD. I had a chance to participate in a French study, which was many years already ago, 20 years. A retrospective review of 33 consecutive patients with histologically confirmed over testicular. The main conclusion was that propagonadal tissue was preserved in 28 cases by selective gonadal surgery. No gonadal tumors were detected during follow-up, quite a long follow-up. Ovarian tissue remained normal, while testicular gradually developed signs of dysgenesis in all biopsy cases and confirmed also by endocrinological studies. However, testosterone production remains satisfactory in majority of cases during reported follow-up. This is a picture, laparoscopic picture of over testicular DSD, and you see the gonade, which is like, looks like this genetic testis with albuginia, tunic albuginia is different, thin and yellowish. And you see, of course, probably specialists will recognize it is very present in many cases, like triangular outgrowth on the pole of the testicle. And histological analysis, of course, is very important here because in these cases, the correct diagnosis is important. Is it over testicular? Is it partial gonadal dysgenesis? And as here, for example, from that gonade you saw recently, we see like follicular and this tubulus, which are intermixed in some places. And that was present in that triangular outgrowth that is at place. Yeah, at the other side of that patient, you see similar like a normal ovary. On the right, you see similar age normal ovary. Yeah, on the left, this over testicular disorder, a little bit abnormal. So the biopsy was taken. And you see here on the top screen, it's like a normal ovary. And here is some disorganized tissue. Darius, you probably could comment. We discussed that slide before.
Yeah, this focus of this biopsy is quite interesting because it have some similarities to maybe testicular tissue. Of course, it was not very classical, but still we have identified some structures similar to testicular tubules.
Yeah, some people call it disorganized or other names for that gonadal tissue. Therefore, what we would suggest in these cases is to make a longitudinal biopsy of the gonade, like in this case, marking carefully, and then asking a precise histology where we see this normal ovarian tissue or some abnormal ovarian tissue, because we want, like in this case, it was a girl, to preserve ovarian tissue which would be normal and to take out something which looks abnormal. Mosaic mixed gonadal dysgenesis. Again, returning to consensus, saying that the streak gonad in a patient with mosaic raised mixed gonadal dysgenesis, raised male, should be removed laparoscopically or by laparotomy in early childhood. Bilateral gonadectomy is performed in early childhood in females with gonadal dysgenesis and Y chromosome material. Again, some slides from this type of patients over testicular on mixed gonadal dysgenesis or XY partial gonadal dysgenesis, they look similar. We have something like this genetic testicle, and then we have this outgrowth from the pole of the kidney, like here, like in all these pictures. And only histological analysis would say us what is there. It may look like normal ovary on the left, or maybe something undifferentiated, disorganized, like few follicular remaining cells, and then some fibrous tissue or granulosa cells scattered around. So there are definitions defined in the literature, and I think it's very useful to call them, to separate clinical and histological diagnosis. And only histologically we may say that streak it is or something else. And clinically we may say only streak-like gonad. Like here, for example, in this 16 years old, streak-like gonad histologically was confirmed to be streak with only fibrous tissue around. XY partial gonadal dysgenesis, 3 years old. What we have laparoscopically, again, similar view, streak-like on one side, and then something like this genetic testicle with different tunical buccinia and triangle outgrowth on the pole. And XY gonadal dysgenesis is probably the most heterogeneous. It may be partial or complete, and recently it is still not a paper, but will be presented in IDSD meeting in Bern this year. It is again based on IDSD registry, and I may only say, make conclusions which will be discussed, of course, that germ cell cancer occur more frequently in complete gonadal dysgenesis compared to partial gonadal dysgenesis. Although the age of diagnosis is different, because complete gonadal dysgenesis is usually diagnosed later because they don't have ambiguous genitalia. Therefore, the risk of cancer, of course, is bigger. But another important decision was that partial gonadal dysgenesis boys had the potential to develop puberty spontaneously with preserved gonads, and we would confirm that from our data also. Darius, your stage about some interesting cases.
Yeah, and I, as pathologist, would like to show you two cases of maybe a little bit similar. And first case is of 15-month-old patient with disorder of sex development, and the patient have mixed gonadal dysgenesis with mixed karyotype analyzed of dermal fibroblast and leukocytes, and patient underwent bilateral gonadectomy, and on macroscopical examination we have little bit similar, but also the different view of left on and right gonad. We have streak-like resembling gonad on the both sides. We have similar tissue very similar to fallopian tube on the both sides, and we also saw on left in the left gonad some dysgenetic testis resembling tissue. Next slide, please. And in this slide we see the more or less normal testis with preservation of tubules, and of course all tubules, nearly all tubules was filled with Sertoli cells only, and only scattered tubules have few germ cells like spermatogonia. Next slide, please. Yeah, and also we have similar picture on left and on the right side streak gonads. This means that we on the top of the slide we see something similar to something resembling a streak gonade, but in the lower part of the slide we see the little bit different positive finding. This means some tumor, and this tumor is gonadoblastoma. Next slide. And gonadoblastoma was seen also in the streak gonade on the right side. So we have bilateral gonadoblastoma. Next slide. And we performed the immunohistochemistry, and gonadoblastoma is represented by two different cells type, and this means germinal cells and sex core type cells, and these cells have quite different immunoprofile. This means that germ cells are positive for SAL4 and PLAP, and in opposite sex core type cells they have positivity for WT1 and inhibin. Next slide. So our final pathology diagnosis was like streak gonades on both sides, fallopian tube type tissue on both sides. Streak gonades on the left and on the right have gonadoblastoma tissue, and also on the left side we have some immature testes. And next slide. And another case of another second case of late diagnosis of complete gonadal dysgenesis in patient with XY karyotype of girl phenotype. Bilateral gonadectomy was removed, was performed at the age of 9 years and 4 months. Next slide, please. Yeah, and in this case, we have also a little bit similar situation. We also have identified gonadoblastoma in both gonades, like we can see, and gonadoblastoma we see on the right lower part of the slides, but in the left gonade we identified also a different type of tumor, like we can see on the left side of the slide. This is dysgerminoma. Next slide.
And if you look to the literature, recent literature, literature of last decade, you see many improvements of consensus. We were talking at the beginning of 2006, and now there are different consensuses already on histology and on diagnosis, guidelines of diagnosis of DSD. I would name probably main I was reading is Dutch-Flemish guideline for comprehensive diagnosis and disorders, differences of sex development from Netherlands in 2020, a novel morphological approach to gonads in DSD from France in 2016, state-of-the-art review in gonadal dysgenesis in Texas, USA, variation of sex development, the first German interdisciplinary consensus paper. You may find them full text on internet. Correct diagnosis is essential for the proper treatment. Histopathological interpretation and classification of removed gonadal tissue is challenging and would benefit from international collaboration and centralization of expertise from different networks and different registries created already. Naming just few of them, it's ERN eUROGEN, ERN IDSD, and common efforts already appearing to merge data from different registries to create new X registries from different other registries. And of course, for that, we need some standardization of techniques also, and of meetings like that, deciding what we should use and how we interpret this data. When we're talking to parents and patients, because reference network is dedicated mainly to patients, and we should not forget to talk about prospects for fertility, for tissue cryopreservation, autotransplantation, and of different techniques possible in the future, and to talk about possibility to preserve protogonadal tissue or to remove if necessary. And the take-home messages from this presentation would be that macroscopic or radiological appearance is not sufficient for the proper management of DSD patients. Special tissue preparation and imaging techniques are important for the correct diagnosis and gonadal surgery. A pathologist trained in DSD is of paramount importance, and both cancers and gonadal preservation are important also. And then we should go for questions or discussion.
Thank you very much. Maybe the presenters can now turn on their camera. And if you have any questions, please type them in.
Before waiting for questions, I would add the discussion which was interrupted probably about use of tissue, cryopreserved tissue, and it is clinical already in women. In men, it's only experimental and successful only in primates and mice. But with many people hoping it should start probably in the near future. But at the moment, we are preserving as we can.
Yes, thank you. That's a good addition, I think. We didn't have any questions yet, so in the meanwhile, I would like to tell you all that the webinar has been recorded and will be available on our GoToWebinar platform and our YouTube channel. And I will send the links tomorrow. All links for previous sessions are on our website, as are the details of forthcoming webinars. You can also subscribe to our YouTube channel. Finally, all of you who have attended today will receive a survey immediately after the session finishes. And we would be very grateful if you could spend a few minutes filling it in. And well, I did get a question. It says, why the gonadectomy in the first case?
I understood from Darius' case, he's traveling on the road, probably he couldn't connect right now, but I may answer gonadectomy because the female sex of rearing was chosen, and it is a mixed gonadal dysgenesis and virilized genitalia, and it was discussed with parents, and this decision was like that. Not only because of cancer risk, but probably in this case, if a female sex is chosen, usually we try always discussion ends usually after multidisciplinary team discussion, that usually it is male sex of rearing is chosen and mixed mosaic gonadal dysgenesis, unless it is late diagnosis and parents' decision, and also phenotypically, well, many factors act here. In this case, it was female sex of rearing chosen. So, and then we were just found what we found bilateral gonadoblastoma.
Okay, thank you. We've got another question. Is there an ideal age to perform testicular cryopreservations in DSD?
As I mentioned, it is still experimental. in all male, but in DSD especially. But I think it's very wise to start cryopreserving. There is no ideal age, but our idea is not only everybody's idea is to catch stem cells of spermatogenesis. Is AD spermatogonia, and probably Faruk will add here that they will disappear in many cases of DSD later. So we should go early. Yes, Faruk, your opinion? No sound. The button on the right with the microphone, green, green with the microphone.
I think we should hear you now.
No, now I have it. Can you hear me?
Right.
Yes, we can probably answer a little bit if we look at the 5-alpha reductase deficiency. And there are up to 10 years, pretty normal number of the germ cells in development. After that, beginning of a puberty, the germ cell number is falling down. So maybe ideal time to be is something in first 6 years. To use the biopsy.
Yeah.
And in Cincinnati meeting of pediatric urology, workshop of pediatric urology this year, they presented an algorithm of tissue cryopreserving in Klinefelter syndrome, for example. So it is going on developing.
Now we've got one other question. I did not clearly get your slides on PMDS. Are you suggesting gonadectomy?
In persistent Müller-Dietrich syndrome, yes. No. Usually these are, at the beginning at least, as I mentioned, they are good testicle, and here is a good place for cryopreservation, I think. Usually they are discovered when you try to put them down and you find a tube. Or as we had a case also by finding a pyometra or hydrometrocorpus. So, but usually it's cryptorchid boys, and you are not very successful to put testicles down because it's a ligament of uterus which is holding. So usually you cut uterus in half in order to put testicles down. So you should no, don't take it out, I think.
Okay, well, thank you very much. There are no more questions. I think it was very clear. Thank you very much for presenting this webinar, and thank you all at home for joining us today. Have a very good evening.
Thank you.